So just quickly, generally speaking, this is a printout of what you'd expect from, let me just put a laser pointer there. So for OCT in glaucoma, we want to look at the RNFL thickness, and this is on all OCTs. Ganglion cell complex analysis. This is on some special or some types of OCT that will give this special feature. Then you also have the optic disc matrix, and we'll look at this later on. And as I said, some OCTs are also able to do pachymetry. And if you have an OCT that can document the anterior chamber angle, you can have this as an additional feature. And also, if there are OCTs that can do trend analysis or progression of glaucoma, this is also a feature that you can use. So this is an OCT printout from the OptoView, and it's a basic printout that just shows the nerve fiber layer. Then this is the nerve fiber layer that has been opened up into this graph, the temporal superior nasal inferior temporal graph. It's just a graph that has opened up the nerve fiber layer from the circle. This circle is represented in form of a graph. And then we have the RNFL thickness map. I don't really use this much. I usually use the outer nerve fiber layer analysis, and we're going to look at that. This is a OCT that we usually get from the OptoView. This is one that we get from the Zeiss. But once we have the basic concept, you'll be able to interpret everything that's going on over here. I don't really usually use these parameters on the Zeiss. I'm not sure how, in addition, they're going to help. Once you have all this information, you should be able to make a diagnosis, but other clinicians may find these tomograms useful. So back to the RNFL parameters, we are basically looking at this outer circle. This circle, usually I tell patients it's supposed to be green if it's normal. And the color code also indicates that if it's green, you're within normal limits. Yellow is borderline, and red, you're outside normal limits, and most likely you have a pathology. And as I said before, this graph down here represents the thickness that has been laid out flat. Still, as you can see, this is the temporal, superior, nasal, inferior, and temporal area. So when you look at the RNFL parameters, so in some OCTs, they have only 4 sectors. Others have 8. We usually use the 8 sectors, and others you can break it up into 16 sectors. As I said, we've talked about the color code. Now for the RNFL, for this particular machine, this is the OptoView machine, the mean average RNFL up here, these are the parameters I usually use, is between 90 to 115 nanometers. And you also have to ensure that you know about the is and through. Usually the inferior rim is much thicker than the superior rim, and the averages for the inferior rim is usually much more than the superior rim. So when you're trying to interpret the OCT, also have this in mind. Now, in this patient, for example, you can see he or she has an inferior RNFL defect. And if you do an OCT on this patient, you'll find that this sector would be red, because this is the circle that usually is able to document the thickness, and this area will be red while the rest will be green, representing that RNFL defect. So in some OCTs, they also have the analysis where they compare between the right and the left eye. And this is represented as a symmetry analysis graph down here. So what they show is that any difference between the right and the left eye that is significant is represented by this red bar in some OCTs, while in others, they actually just superimpose the graph together, and you can be able to compare between the right and the left. In most cases, glaucoma is an asymmetrical disease. It's bilateral and asymmetrical. And in some OCTs, they say the more asymmetry there is, there's more likelihood of glaucoma. So now we'll look at the optic nerve head parameters. In the Optovie OCT, there are so many parameters to look at, but you can't analyze it's difficult to look at. These are about, I think there are 8 or 9 parameters. But what I first look at is the optic disc area, and the normal ranges from about 1.82 to 2.25. But I find in adults, they have slightly bigger optic disc areas, and that is represented right over here at the edge over there. So look at the disc. Is this a big disc? Is this a small disc? This average of 1.99, I think it's mainly for Caucasians, because Africans, as I said, we have larger discs up to about 2.5. But you find that the minimum is from 1.1 to a maximum of 3.66. And sometimes if the disc is so big, the OCT may not even be able to interpret the results. Another thing, if you want, you can look at the cup to disc area ratio, but usually I look at the vertical cup to disc area, which is the, where is that? The CDR, the vertical cup CDR, and compared with what I have in my notes. Other parameters, you can look at them, but the most important thing for me, I think, is to look at the disc area and the vertical CDR. The rest, I don't put too much weight on them, because as I said, there are so many parameters to look at. This is a patient with a very, very small disc. So if you do an OCT on a disc like that, you can see when you compare this patient's right eye and the left eye, the right eye has glaucoma. The RNFL thickness is very low. Remember, we said it should be between 90 to about 115. And you can see the right eye is at 30. The left eye is at 79. And what is important here is when you disc area on the right, it's really, really small, 1.74. The left is also small, it's quite small, but the left does not have glaucoma. And when you look at also his graph over here of the neuroretinal rim thickness, it's quite affected on the right as compared to the left. Also of importance, especially when we think a patient has physiological cupping, is to look at the size of the disc. The large discs. This disc is so large, it's almost the size of the macula. Now, this OCT represents a patient who has had very large discs. Look at the discs, they are 4.18 on the right and 3.69 on the left. So he may have glaucoma, because you can see his RNFL is quite thin. But as I said, sometimes if the OCT, if the disc is so large and it's outside the OCT can measure, you may not get something accurate. But in this particular case, probably the patient may have had glaucoma. You have to look at the clinical findings. But it's important to note that the discs are very large. Now, quickly, we'll look at the ganglion cell complex. This is a new technique of diagnosing especially early glaucoma. And it's what people are using now to help know whether, the patient has actually glaucoma or is about to develop glaucoma because of the things I'm going to mention shortly. So when you look at the layers of the retina, as we know from anatomy, there are about 10 layers. Now for the ganglion cell complex, what we're mainly interested in is from the 7th layer going inwards, and that's from the inner plexiform layer, the ganglion cell layer, and the nerve fiber layer. That is our area of interest. And this is all these layers form what is called the ganglion cell complex. So what is the importance of this in glaucoma? So in glaucoma, what has been shown is that the ganglion cells, they die. yeah, because of all the theories of hypoxia and ischemia and mechanical damage. So the ganglion cells die. So as a result of the ganglion cells dying off, the axons die also begin to die, and there's a thinning of the nerve fiber layers, because the axons are basically the nerve fiber layers, and they're the ones that converge at the level of the optic disc. So if you have death of the ganglion cells, you'll have subsequently thinning of the nerve fiber layers, and also the dendrites of these ganglion cells will be lost at this level of the inner plexiform layer. So why is it important to measure the ganglion cell complex? You find that at the macular area, the macular region, it contains about 50% of ganglion cells when you compare it with the whole of the retina, and especially at the perifoveal area, there are about 6 stacks of ganglion cells. So when you assess the ganglion cell complex at this region of the parafoveal layer, you're going to get an accurate measurement of if the ganglion cells start dying off as a result of the glaucoma, you're going to be able to measure it a bit more accurately in that area. And this is just a normal OCT, just showing that what happens when you take the normal OCT we know of the macula, the ganglion cell complex around the parafoveal area is quite thick there, but you see with glaucoma, it starts thinning out. And this is the area that is actually measured once we look at the ganglion cell complex. So the average ganglion cell complex is about 97, but it can range from between 95 to 100. And it's also useful, just the same way you compare the superior and inferior RNFLs, to also compare the superior and the inferior ganglion cell complex when you're trying to interpret an OCT. Now, in some other machines, like this is the machine from the Zeiss, they have the same ganglion cell complex analysis. And like you can see in this right eye, it's normal. However, in the left eye, the superior aspect is quite thinned out, and it's simply recorded as, they have recorded it here and have shown that, yeah, it's red meaning it's abnormal. So as I said, once you know what basically the ganglion cell layer is and how to interpret it, you'll be able to interpret this from any machine. Okay, so quickly we'll look at OCT in advanced glaucoma. We've actually gone through how to interpret an OC printout within a very short time. But as I said, this is a very clinical look at just important aspects. Now, advanced glaucoma, as we know, this is a patient with a CDR of more than 0.9, advanced capping, very advanced visual fields, like we usually see them. Most of our patients present like this. Now, is OCT useful in these cases? So from literature and from what we have found is that very useful in advanced glaucoma, because you'll have what is called a red flow effect, a flow effect. Everything is just red. The line is just in the red. And this is especially when the RNFL is at the level of between 40 and 50, because all you're getting is just a measurement of the residual glial tissue, blood vessels, other non-neuronal tissue. So you find if a patient has a CDR of 1, you don't really need an OCT to this diagnosis or to follow the map, because you will repeat that OCT and it will all the OCTs will just look the same. So you're not going to get any new information. So usually in patients with advanced glaucoma, bilaterally, I don't really request for an OCT. But if somebody has maybe early glaucoma on one eye, advanced glaucoma on the other, you want to compare the two and also show the patient, you can do the OCT in both eyes. But if it's both eyes CDR of 1, you're not going to get any new information from that. Now let's look at other terms that you may come across, and this is very important when you're interpreting the OCT. So we know that the red colors and the green colors are used by the OCT to identify. Red is usually when something is abnormal, green when something is normal, and yellow is borderline. But in some cases, we have what is called red disease. And red disease is a false positive. That is when the OCT mistakenly indicates that something is abnormal, but it's not. Okay? So it says this is abnormal, but it's actually normal. Okay? Green disease is a false negative, where the OCT data shows no abnormality at all, but in fact, the eye is abnormal, meaning the eye has glaucoma, but the OCT is showing that it is it's normal. Okay, so let's look at some clinical examples of red disease. So this is a patient who had physiological cupping. So that's what their red-free disc photograph looks like. And you can see the pattern deviation is very clean. However, the OCT has some red areas and some yellow areas, and we're going to look later on at sources of error. Why would you get red, especially when things look very normal? And there are some sources of error we are going to look at just shortly. So this is an example of a red disease. Now, in some conditions of the eye, you can also get red disease. The first one is it's just physiological cupping, a large disc. The second is in B is pathological myopia. C is optic atrophy that is not glaucomatous. For example, if it's as a result of intracranial tumor and the disc is atrophic, or any other causes of optic atrophy. D is a disc coloboma. E is a patient who has a macular lesion. Maybe if you do a ganglion cell count, the ganglion cell count will be reduced, and you might interpret that as glaucoma, but it's not. And F is when you have a huge peripapillary atrophy, the RNFL will turn out to be quite red, but yet it's just the patient who has a peripapillary atrophy. So moving on, let's look at green disease. So in some patients, they have little focal areas of damage from glaucoma, especially these are patients with very, very early glaucoma. So you find that the machine it's mathematical. It will take the average thickness in each sector, and since it's just a small focal area, the average may be normal. It will be within normal despite that focal loss. So the whole printout is actually green, giving the impression that there is no glaucomatous damage present, but the patient has a small area of notching that somehow got lost or was not brought out when the machine calculated the average. So for example, in this patient has a normotensive glaucoma. The red free filter, it may not be very clear here, but was showing an area of RNFL loss in this sector, which was represented in the visual field machine. In the visual field printout, the pattern deviation showed an inferior defect. However, the OCT was quite normal. But when the OCT took the average, it brought it normal. So this is what we call green disease. So really, when you're interpreting the findings of an OCT, you have to have seen the patient. So you can't just have an OCT and say, oh, this patient has glaucoma or not. You have to look at the patient's optic disc, you have to take their pressures, you have to look at their visual field, and then come up with a proper diagnosis. So quickly we'll look at potential sources of error in OCT. And one of the commonest things are the signal strength. So if the signal strength of the light is not good enough, is not good quality, maybe there's a media opacity or the placement of the patient on the machine, then you're not going to get a very reliable printout. The best signal strength generally are above 80, depending on the machine you use. Acceptable signal strength are above 60. So look at your machine, and usually all machines print out the signal strength, and they'll say it's either good or poor or bad, and instruct you to repeat it if it's not reliable. Other sources of error, as I said, are media opacities. If you have a cataract or a vitreous hemorrhage that will impede the light from reaching the retina for the image to be taken accurately. Um, if you're taking, let's say, the ganglion cell count and you're looking at the macular area, there could be edema, there could be atrophy. All these are potential sources of error, and you cannot interpret your ganglion cell count accurately. Also, if you have extreme disk size, if it's very large beyond what they have in the database, or very small, also at the other extreme end, you may not get a very accurate result. If the patient is blinking excessively, you're not going to get a good signal, because there's interruption in how the machine is taking the measurements. Also, and this is very common, the patient is not focusing on the blue light, especially when they have poor vision. So if a patient has a CDR of 1 and their PL, and you're asking for an OCT of the disc, they cannot even see that blue light they're supposed to see. So you're not going to get an accurate assessment. So these are factors that you need to consider when you're doing the OCT, or requesting for the OCT, and also when you're interpreting the OCT. Another thing, like I have said, the database may be not exhaustive. They might have measured only 500 patients. Of those, only 50 are Africans, 50 are Asians, the rest are Caucasians. So you'll find even within the African ethnicity, they don't have enough to compare the full range. And when they're comparing, when you have your printout, they're comparing with the database in the machine, so it's not exhaustive. Also, they don't include in the database. They usually just include normal patients. They don't include high myopes who have increased axial length, and of course, the longer the eye, the thinner the RNFL, the smaller the disc area. You're going to get red disease from that. Also, they don't include high hyperops. They don't include children. You find that if you really have to do an OCT on a child, and you want to get some comparison of sorts, you have to indicate that the patient is 18 years, so that you can have some sort of printout that will compare with what is in the database, because the cutoff for most machines is 18 years. As I said, we have different races. You have peripapillary atrophy, discs, and other anomalies. All these are not included. So these are potential sources of error. Other things you need to be aware of is if the technician is not sure on how to position the patient, ask the patient to look at the light. If they're not friendly, then there'll be also a eccentric placement of a ring. There's a ring in some of the machines, I think in the top cone and the Zeiss, I'm not sure, that has to be at a particular area. If this ring is I mean, I get some OCTs where the ring is supposed to measure the RNFL and the ring is somewhere near the macula. You can't interpret that. So your technician has to be very good. And of course, if the patient has tilted their head or there are some microsaccades in the eyes, you're going to get different readings, or you can get some sources of error from there. So these are things you have to keep in mind. Now, quickly, we'll just look at, I talked about OCT use in progression. So this is the OptoView, and this is a patient progressed from early glaucoma all the way to advanced glaucoma, more obvious on the printout of the visual field and on the ganglion cell count. Somehow, the RNFL is not as severe as the visual field findings, but this is a good example of how you can use the progression program within your OCT if you have it. Most of the Zeiss and the OptoView have this program. So look at quickly clinical examples. And this is our first patient, fairly normal disc, no CDR, everything looks normal. And that's his printout of his OCT. Everything is nice and green, nothing abnormal about that. Our second patient, so this patient had very, very early glaucomatous features on the right, maybe on the right. She had high pressures in both eyes, but the right eye you can see has a normal RNFL. Everything looks normal on the right. However, the ganglion cell count was showing some defects, especially in the parafoveal area, so we need to keep an eye on. But the left eye, you can see, has quite some damage, both on the RNFL and in the ganglion cell analysis. And her visual field, right eye was fairly normal, okay? So we needed to just monitor it closely. And the left eye, you can see, already has a superior arcuate defect. This is a patient who has advanced glaucoma. These are the patients who really, you can see his RNFL there is 56 and 56 at both eyes. This area is fairly small, 1.98, 1.95. And his vertical cap to disc ratio is 0.9. So this is a patient who the OCT is not going to add any more value to your clinical diagnosis. And those are his visual fields. Completely, he has almost tunnel on one eye, and the other eye is also quite advanced. This is a patient who has a fairly normal OCT, but sorry, it's a bit small. His disc area on the right was 2.4 and on the left was 3.30. So this patient had disc asymmetry and was actually diagnosed as glaucoma because of the asymmetry. His and his discs were asymmetrical because I was let me see, 0.6 and the other eye was 0.76 or 0.8. So this was 0.6 and this is 0.8. But because one disc was a normal size, 2.4, but the other disc, the left disc was quite large, and hence the asymmetry of the vertical cap to disc ratio. So he was referred as a case of a glaucoma suspect because of asymmetry, but it was because of the disc size. But he's actually normal, as you can see, and those are his visual fields, where the right eye is normal and the left eye just has an enlarged blind spot in keeping with the large disc on the left eye. So we didn't start him on any treatment. Just a few other clinical examples before I finish. So this is an OCT of a patient who has optic disc drusen. And you find these patients have very, very thick RNFL. So when you find the RNFL thickness has gone beyond the normal, you'll have white areas, yeah? And this means it's way above even the normal database. And this is because of the thickness attributed to the optic disc drusen. In this case, it was bilateral. In optic atrophy, you're going to get all sectors will be completely red because of the nerve fiber layer loss. And this is a printout you're going to get in optic atrophy. So also in disc edema, this is a patient who had unilateral disc edema on the right eye. You can see the nerve fiber layer is quite swollen, quite thick, and this is also represented over here. It's way above, it's way, way, way above normal. So that's why it's looking all white, because it's really out of the normal database. And then I think this is on my final one. This is a patient who has myelinated optic nerve. So also in this case, you will find, this is for the left eye, you'll find that there's a lot of white areas because this is way above normal. And when you examine the patient, you have my eyes are very difficult to interpret because you might think it's red disease, but maybe they have pathological myopia and glaucoma. So they're very, very difficult to interpret. But in this particular patient, she had normal visual field, normal visual fields and normal intraocular pressures, but you can see the OCT, everything was just red and abnormal. So in conclusion, it's very useful in glaucoma. OCT is very useful in glaucoma, documentation, diagnosis, progression, because we can document optic nerve head findings, ganglion cell complex, central corneal thickness, and angle analysis in some of the programs. You have to be careful about the interpretation of an OCT, especially in the cases of red disease, false positives, and green disease, false negatives. But I think the final take-home message is that the results will be interpreted fields and the patient clinical assessment. Don't make an isolated diagnosis just from an OCT printout. You really have to have seen this patient and seen their visual field. So that's Professor Damji. He was having his OCT done at our machine at the dental school, University of Nairobi. He kindly donated this machine to our facility, and we thank him for it. Okay, thank you. That's the end of my presentation.
Thank you, Dr. Shira, for the excellent presentation. I just wanted to remind you once again that we are live on Facebook, we are live on YouTube, we are live on Workplace, so a lot of people can be watching us, and it's being recorded. So back to Shira. I think I thought I'd had it all, but there's a lot that I'm learning. I like the way you have explained some of the concepts very easily, like the concept of the ganglion cell complex, the red disease, the green disease. And I like the way you've tried to explain how the structure and function should be related. And that it's really necessary as doctors to know that what you're seeing, the OCT, you want to know that it's really affecting the patient as it really change the function of the eyes, and that is necessary. I hope one day there will be a machine that will have both the structure and function. You may not be, and maybe let me just get a chance to ask you one or two questions.
I'll be in. It's just that the room will be dark.
You would accept the question. What are you really saying about the OCT in children, and what is your recommendation? We don't have the normative data for children under the age of 18, and yet I see so many OCTs for children under the age of 18. And so what is the best practice? Should we just say we don't do OCT under the age of 18, or what is your recommendation?
Sometimes you really need to do the OCT. Children who need OCTs, the OCT should be done. What I know about the OptoView machine, I'm not sure about the Zeiss and the Topcon and the Optofol and the other models, but in the OptoView machine, their database is from 18 and above. So if you put age as 8, the OCT, it will still be done, but you won't be able to, it won't be able to compare with anything. So everything will be white. The whole printout will be white. If you put the age of the child to be 18, then at least you can compare their RNFL with an 18-year-old, which may not necessarily be accurate, but sometimes you really need to get that information to decide whether you treat this child for glaucoma or they have another pathology. So I don't have experience with the other machines, but OCT, if indicates child, it should be done. If the child can concentrate and focus on that light, it should be done. But I know there's that limitation in terms of age with the OptoView.
Thank you. So, so I'm glad that you'll be there at the end. So I'll invite other people to be asking questions, and please do it on answer. And right now, we could wish to switch gear, and we could wish to invite Dr. Faith Masila, who is a new kid in the block. Faith Masila is an ophthalmologist and a glaucoma specialist from University of Alberta. And she's the medical director of Kikuyu Eye Unit and glaucoma specialist. So Faith, I can see you
Thank
are
you.
loading your screen, and Faith to talk to us about visual fields. And yeah, Faith, please take it away.
Thank you, Professor Kiage and Dr. Sheila Marco for the wonderful presentation. I'll just do a talk on visual fields, the interpretation of visual fields, how to monitor progression in the fields, and the new testing strategies that have come up recently. This will be the outline of the talk. As we know, in glaucoma, the functional status is best assessed with perimetry, of which the three commonly done perimetry tests are the standard automated perimetry, which uses a white stimuli on a white background, short wavelength automated perimetry, the blue, which uses a blue stimuli on a yellow background, and the frequency doubling technology perimetry. For the purposes of this talk, we will talk about the standard automated perimetry. So we have the 30-2, which is the 72 test points, and it extends to the periphery up to 30 degrees. The 24-2 has 54, extending to 24 degrees peripherally, except it extends to 30, and the 10-2 is for serious damage with a central remaining field. So this is the visual field, and it shows the various parts. We have the reliability indices and the other factors that we input to do the test, such as correction, the date, the age of the patient, the grayscale, the numerical scale, the total, pattern standard deviation, mean deviation, pattern standard deviation, and the probability values. So there are sources of errors which we can find in a visual field, and it's important to note them so that the visual field correctly. And these are the blind spot being mapped on the wrong side, a drooping blind spot, a wrong date of birth entered, a pupil, myotic pupil, uncorrected refractive error, a rim artifact of the spectacles, media opacities like cataract, ptosis, and inadequate retinal adaptation. So I'll just give pictures of the same, which you can appreciate so that we can be able to note them down. So this is a blind spot mapped on the wrong side. The field is written OD right eye, but the blind spot is, instead of being on the right, it's on the left. So it appears as if it's an extension of the visual field defect, but it is not. When you have the wrong date of birth entered, in this case, the field was input compared to that of a 6-year-old, but the patient was much older, and it brought more defects, a mean deviation of -6.7, while a repeat field showed a -1.252 decibels. In a myotic pupil, again, it will lead to more defects showing up, as you can see in the 1.5 millimeters pupil compared to the 4 millimeters pupil. And this is a wrong correction in the refractive area. The patient was a -3.75, but was put +3.75 during the test, and it showed more errors. This was a patient who had undergone LASIK. The correction before LASIK was -4 diopter spheres, and it gave some defects with a mean deviation of -4.81. After correction, the patients performed better, and the patient admitted they had done a LASIK, and the correction was removed, and the mean deviation was 1.02, a good field. These are the components. Look in the reliability indices, the fixation, false negatives, which actually ahead and use that test to tell whether it's reliable. Fixation losses greater than 20% and false positives and negatives over 3% are significant, and the field is usually unreliable. As you look at the fixation loss, it's good to look at the gaze tracker, which is usually input at the start of the test, and there's an image at the bottom which tells how steady the fixation is. Dr. Marco has talked about the size of the optic discs. So in this case, this patient had a small optic disc, and it appeared as if from the visual field they have a lot of fixation losses. But that is how the Humphrey picked it up. because but the patient was actually fixating, and you can confirm that using the tracker. In this case, the patient had a large paraparotrophy, and the visual field print there was one fixation loss out of 18, but in actual fact, this patient was not fixating well, and even the gaze tracker could be able to demonstrate that, as there's a lot of upward and downward spikes. So it's good to look at the gaze tracker. After looking at lost, just go down and look at the gaze tracker. This is the high false positives. They appear white. The visual field is abnormally white. Patients tend to click, most of them anxious, young patients who really want to perform well in the test. So they keep clicking, and it gives false results. In this case, they had a false positive of 57%, and even brought a disconnect. In high false positives, you find the pattern deviation is from the total deviation. So that is not a true defect. In this case, the patient repeated the test, but now was allayed their fears and their anxiety, and the test performed much. High false negatives, this is just the opposite. Patients who lack concentration, so they stop clicking, they could be tired, they could be sometimes elderly, and this is a cloverleaf pattern, characteristic of inattention, and it appears abnormally black. So the other one, false positive, was abnormally white. The false negative is abnormally black. Media opacities can bring defects in the visual field. So the Humphreys visual field corrects by pattern deviation, and you're left only with the focal effects, which are due to glaucoma. This is a drooping blind spot. This happened during the beginning of the test. The patient focused down when the fovea was being marked and forgot to look up again. And so it appeared as if the defect is extending below horizontal midline. And after a repeat, when the blind spot was marked properly, the proper horizontal midline was maintained. The gaze tracker, to note the upward fixation are usually fixation losses. Downward spikes occur when the fixation cannot be measured, like blinks. Rim artifacts is common with spectacles, and how you can tell this in the numerical scale, there's a sudden drop-off to 0. So usually it's gradual, but you can see suddenly it drops off to very few numbers, and the defect is only at the rim. The lid artifacts are also picked up. The edges are not following the glaucomatous pattern, and with such patients, you tape the lid and you do the test, and the defects will be reduced or no longer there. Another thing to remember is learning that patients may not perform very well in the first, but as time goes by, the field will improve. So like in this first case, the upper field, there were what seemed like early defects, but after a repeat field later, when the patient has now understood that, the test was reliable. The other thing to remember is that despite how like bad or poor a field can look, sometimes overall you have to look at the patient, and if they have obvious correlation with the clinical picture, don't negatives, but overall the patient had glaucomatous defects on field. This is an example of a case whereby a pattern deviation plot is not generated when the field advanced, the mean decibel of minus 32.15, and the pattern could not be plotted. But when the patient did a 10-2, it was plotted, but there were no. So it's a case where it looks as if the pattern deviation is better, but this can happen in advance, where the total deviation is would rely on, as well as the grayscale rather than the pattern deviation. So this is just a remark on the use of visual fields in diagnosis of glaucoma. The important thing is to remember is to use the same test pattern and strategy for follow-up. We should not keep changing the strategies and the pattern. And the various glaucomatous defects that the paracentral scotoma, the nasal step, aqueous defects, enlarged blind spots, ring scotomas, and the diffuse field. Used to determine if the field has significant defects, and one of the criteria is a minimum cluster of statistically depressed points, at least one point that is significant at the 1 or 0.5% level, plus 2 neighboring locations with lower significance, 5% or worse. The other criteria is an abnormal glaucoma hemifield test, which is a mirror image comparison of the superior and field, and a pattern standard deviation of less than 0.5 probability level. So those are the slides. So the first one is a paracentral scotoma, and the second one is step. The third one is an aqueous scotoma. The fourth one is a blind spot that is enlarged. The fifth one is a ring scotoma, and the last one is a completely diffused and depressed field loss. So the exceptions when we have to strategy that we used doing visual fields, like if it's a serious field, we normally switch from the 24-2 to the 10-2 so that it can provide more test locations to monitor the central field. And also, the other time you would change is when you need to switch to a larger class, like from size 3 to size 5. If it's a very advanced case and the patient cannot see with a size 3, you may just have to switch to size 5 and continue with the size 5. And also in the binocular field testing, sometimes the glaucoma patients are required to have a test to see if they're fit for driving, and the binocular test is used because in cases eyes have a really constricted fields, and if the patient really wants to drive, you may consider doing an Esterman, which is now a binocular test. So that is how the Esterman visual field looks like. It's also in the Humphrey, test the horizontal all the way to 130 degrees and the vertical as well. So the mean deviation and the pattern standard deviation and the visual field index, they are which summarize the sensitivity of the field, and they can be used mostly for follow-up and disease staging. Not commonly for diagnosis, but mostly for follow-up and just if you want to stage the disease. So early glaucoma, the mean deviation is -6, less than -6, moderate -6 to -12, and severe greater than -12. So visual fields in progression, so the thing we want to ask ourselves in a field, has it progressed or not? And if it has, what is the rate of progression? So you use two methods to check progression: event analysis and trend analysis. So event analysis will help you to determine has the field progressed or not. And it's really used for early progression, and it will do earlier than the trend, because the trend, you need very many fields, quite some significant follow-up. But event, even about 3 times, this will tell us the rate fast or slow is it. It can tell fast progressors, slow progressors, and it can tell whether that trend is statistically significant. So the event analysis, they take point by point basis, then they find localized areas where there's a beginning of field loss or a deepening of the existing field. And this, the glaucoma probability change maps are an example of analysis. So this is an example. On the right side there, it's written the GPA. And what happens the first time that a worsening is detected, there's a symbol which is a point, which is like a triangle that is playing. And then the second time, if the worsening is confirmed, in the second time, the other field that you do, the goal now in the second field is a half field triangle. And then now the third time, the test has been done and the defects are still persisting, or they are deepening, or you find a solid triangle is the one that shows up. So when you have with these 3 solid triangles, most likely to have progressed. So an example of an event analysis, and it shows whether there is progression or not. Trend analysis is calculated by a linear regression analysis of the mean deviation index. So it gives the rate of change, and so that it can help the clinician make the appropriate decision so as to risk of that person losing their sight. And it's usually presented in an age diagram, which can be extrapolated and see whether in this patient they are likely to lose their vision. So this is an example of a mean deviation analysis. So at the bottom there, you can see that this patient has several fields. Mean deviation has been plotted, and now it's being the trend at mean deviation. See, is it declining? Is it remaining stable? And if it's declining, you can decide to intervene. You can decide you want to do a surgery like a trabeculectomy. You want to be more aggressive. If it's stable, then you just continue monitoring. This one shows a field analysis. And at the bottom there, it gives in percentages. It's good. Visual field includes even the center of the field, which mean deviation may sometimes not include. And it shows, it starts at when the patient started doing the fields and continues throughout. So for this patient, it looks stable because the VFI is very high. But for some patients, that graph can rapidly decline. So depending on how fast it declines, the intervention will match how rapidly it declines. You can also have a patient who has a stable VFI. They started like 20%, but it's been stable. Then you may not need to be aggressive. It's just that they started lower level, but they've been stable. So this is also available in the Humphrey. So the rate of progression is expressed as how many decibels per year has based on mean deviation, and how much percentage per year has the patient lost if it's based on visual field index. And 1 decibel per year corresponds to about 3% per year. And we've said the VFI can be insensitive to the edges, but it's the central point. So then this rate is presented together with the individual tests, and an age function diagram is plotted. In this diagram, we see there are 2 patients here who have the most similar rate of progression, but one had better mean deviation, so they're not likely to lose their sight. But the other one, who had started at -20, they are likely to really have a very reduced vision by the time they're actually going blind by 90. There's also another patient, the one in red, who started at a high mean deviation, but progressed very rapidly. The first progressor, he was progressing at -2 decibels. So has declined and even gotten blind before the other 2, who are progressing at a rate of -0.2 decibels. So this is how the VFI can help, if one can see every one. So this is a printout, an overview that comes again from the Humphrey. It gives a summary of all the visual fields done for the patient. And at a glance, one can look at all the fields without really having to flip through very many pages. And this is how it looks. So like here, we see the patient had done 2 fields. We already have a grayscale, a numerical scale, a total, and a pattern deviation. And the first case, they had false positives. They had a lot of false positives. The second case, the field was more reliable. They had only 4% false positive. And you can get an overview of visual fields done for very many years. Just ask for the overview, and it will only print the overviews alone. So this is a view of a patient who is being followed, and on looking, the VFI was 60%, and suddenly it declined to 40%. In this case, one actually thought that they have sent, but a repeat testing was done. The VFI that happened was that the pattern deviated was not generated. We had said for a mean that is really bad, like -20, VFI now will be calculated from the total deviation instead of the pattern. And like the progression, but on repeating, it was not a true progression. So this is just briefly on the testing strategies. So The visual fields have become faster over time because of new thresholding strategies. Initially, we had the full threshold, then the CETA standard, CETA, and the newest is CETA, faster 24-2C. Full threshold, if we remember, the initial stimulus is presented and the light is dimmed. And this is done until the patient cannot see. And now when they cannot see, light of a brighter stimulus is added. So in this case, the patient at 24 days, the area of not seen was at 28, but at 24, it was a brighter stimulus, so they could see. And then they made it a bit more dim, and then they dimmed it again until the patient could not see. So it uses it's called a double staircase strategy, double staircase or a bracketing twice. From unseen, then to seen, then back to unseen. And in the CETA standard, it doesn't use this strategy, but it estimates it. So in this case, it identifies a region whereby the patient can see, like that area of 26 decibels. Uses that now to map. So it can go straight away from bright to slightly dim, or it can go from a very dim light to a bright. So it doesn't really test it twice. It goes straight away from area of either seen or to unseen, or just from unseen to seen. So this makes the test shorter than the full threshold. In the CETA, what happens is that the window is widened. So if the machine has 26, that is the area that the stimulus is seen, it widens that window such that decibels is allowed into that window. So as long as a bright light is shown, the patient responds. So it even takes a shorter time, and it takes 30% of the time that is taken in the CETA standard. So it's good for the patients who really find the CETA standard still a bit too long, but important to note is once you do a patient CETA fast, then all the subsequent fields must be CETA fast. It's not good to switch into standard. Then the CETA faster, the time takes 30% less than CETA fast and 53.5% less than CETA standard. And the stimulus, 21% less than CETA fast. So again, it's an improvement of the CETA fast. And time is really short, 2 to 3 minutes. CETA faster 24C, this was developed mainly because it was realized that the 24-2 will not test as many points in the center field, yet the patient may be having early central loss. So they included 10 additional points at the center so that they can test even the center almost simultaneously at the same time as you do the 24-2, the center is also tested and can give an early clue, is there macular involvement. So this one is a brief. It combines the structure function report, the OCT. Okay, some machines like the Zeiss can combine the OCT and the Zeiss field. They can combine both the OCT and the visual field, and at a glance, one can look and actually see the corresponding areas of where the nerve fiber layer is affected and the corresponding visual field effect. The same can happen also for progression, whereby just the visual field progression is plotted the same way the OCT progression, and you can still combine the two progression, the progression on the fields and the progression on the OCT, and all this can be put in a glance. One can just have an idea of how this patient is progressing. Yeah, so that's the end of the talk. Thank you, I finished my talk.
Yes, Faith. Thank you very much. Wonderful. I can see you truly went to Alberta. You're not hiding somewhere in Kitchener.
I also went to Australia, so I also trained in Australia.
That adds the more. Many questions, and looks like most of the questions are actually on visual field. And since you've been busy, I'll help to read them for you. About 5 questions, and they're all for you. So the number one from Munira is, does this information apply to information from a Humphreys visual field only, or does it apply to other machines like Hanson or an Octopus?
Yes, so the information applies to all the visual machines. The only difference I've seen is that the Humphrey is able to do the overview, the VFI. Yeah, that's what I've come across. But yes, interpreting the visual field is for all machines.
And the clerk here is wondering, how does one differentiate errors in the visual field test from actual defects? Is there an indicative value? Is there any indicative value?
Pardon? Just ask the question again.
How does one differentiate errors in visual tests from actual defects?
Okay.
That's errors in visual field tests from, is there any indicative value?
Yes, from looking at the artifacts, which you have said, you can look at the sources of artifacts. Of course, you've examined the patient, you know if they have a corneal opacities. The pattern standard deviation really helps because it really eliminates a lot of the defects that are not due to glaucoma. It tries, the machine really tries to eliminate the effects that are not due to glaucoma in the pattern standard deviation. That's why you find it's a common practice when people are interpreting fields. Immediately they look at the reliability indices, they go to the pattern. But we have also learned there are a few cases where the pattern may not be the true picture, and we've given examples of those. But that's why people tend to go straight to pattern deviation.
Good. And Duni is wondering, what could be considered a reliable visual field for pilots?
Yes, that is an interesting question, because the few times I have seen, maybe once or twice they come, we had been doing the 24. For the drivers, we did, we are now doing Estaman in Kikuyu for the drivers. For the pilots, I have been wanting, because I know one of our colleagues is testing pilots, an ophthalmologist. I've also been, it's been the back of my mind to ask, what do they use? I just keep forgetting. I've not tested since I came back. I've only done now, I switched to Estaman for the drivers. So we do need to explore for the pilots what would really represent a good field for them.
If I can help you there a bit. So pilots, we really use the Estaman, and there's a way of doing it. You know, there's the Estaman monocular, and you can also do Estaman binocular. And so one needs to do both. And once you've done it, and it's been done correctly, interpretation of that is very complex. And there are some authorities, I think from UK and from Canada and from America, they have given various methods, like how many spots one needs to lose to be considered normal. So the thing is that you do Estaman monocular and also do the Estaman binocular, and then refer to the guidelines that have been given by these authorities. I've done some, and that is, I mean, that is quite complex. If you read it, you can Google it out or something, and you read it and see how they now this is normal. Because even the Estaman for drivers is also, the interpretation also depends on those authorities. Like I think there's a UK one which are, if this is a result you've gotten, so can this person drive or not? So you have to refer to that, and then before you write the report and say in this UK authority, because you don't have authorities for Kenya.
In Kenya, yes.
And the UK authorities to say man agrees with the UK authority that it can try pilot. So I think that That's the answer for that, Duni.
Okay. Thank you.
And Patrick, I think this PT, I guess, is saying, at which interval shall we do visual following a glaucoma patient?
Yeah, so fields, in general, like glaucoma, you have to tailor it to the patient. So understanding, their cooperation, fatigue. If it's a patient who's just young and they're, you can do fields very, very frequently. Again, depending on the stage also of the glaucoma and whether you're suspecting a fast progressor or a slow progressor. But most of the time, I find on average, I can do 2 fields in a year. I do just like 2 most of the time.
Okay. So then I think it's another question here. I think this is from Tony. FDT again is some phrase. Any comments?
Pardon?
FDT against Humphreys. And I think that's from Tony.
Yeah. Mostly FDT is good because it's a shorter time than the SITA standard. So the patient is not likely to get fatigued. And it's also useful for screening for defects. So I'll just say if one has an FDT, it's also good. Use that. Use what's available. Yes, follow these patients.
Okay. Then Dr. Kipsang here is who want to have disability forms for tax exemptions.
Yes, so we do the visual field for them, and we do to the 24-2, we do the 10-2, and then we classify that and in the WHO classification, and then we give them, like in a hospital, we give them a note for visual impairment. So depending on what 10-2, they're eligible for visual impairment. Yeah.
I think there's a comment here which is interesting from Kahaki, or she said for pilots, Goldman perimetry is considered gold standard and has to be 135 degrees in the horizontal fields and 70 degrees in the vertical fields. If you have any comment about that, or Sheila, do you want to comment about that?
So I have no experience with what the pilots in Kenya, because I don't examine pilots, but maybe that is something to look into. It would be interesting to know what sports she's referring to, because we know for the Goldman, there comes in sport sizes and different light intensities. As you had said earlier, Dan, different countries have different recommendations for both their pilots and for their drivers. So it's a matter of looking at what the Kenyan one recommends. Probably it's this that Tahaki has mentioned, but I'm sure they also have specifications for the spot size, for the and the intensity of the light for the field. So it's just a matter of looking at the small print and conforming to that.
Okay. You know, the other thing I have to say is that you might be frustrated for some of the older machines which will not show some of these things like the Esterman or some of these analysis that Masila has talked about, event analysis, trend analysis, MD analysis, the overview. So I think the machines before 207 don't have some of these things, and machine and do this. But I think in terms of pilots and drivers, we need to at least look at some of these countries are and maybe we can adopt it for Kenya. Maybe I think Faith, you'll be happy to take that up.
Yeah, we can.
So I don't see any more questions, but I just have some questions for both Sheila and Faith. You know, in this RORIS setup, what are really the indication, and Sheila, what are really the indications for OCTs, and talk about the, especially if you get a patient who probably has gone Sarah goat to do the OCT and actually the cost of a goat is actually the same price of fee of doing any of these tests. So what would you say are the indications in a resource setup? Can you enumerate some of the things which you really must ask lady to go and Sarah goat to do it? Maybe you can go Shira first, and then Faith, you can also talk about the future field.
Okay, strictly as to sell a goat, I'll have to rely very strongly on my clinical acumen. I'd prefer that I get my clinical acumen correct, and the patient can use that money to medication or seek side intervention or whatever more relevant. But basically, OCT, as I said, really the patients who are CDR of 1, you know, those ones don't really need an OCT because they have glaucoma for sure. And at the other end of the spectrum, if somebody is absolutely normal, your cut disc ratio is 0.3, your visual field is, or your 10, you don't need an OCT. But the guys in between, where you're looking at the normotensive glaucomas, you're not sure this patient has optic disc that are consistent with glaucoma, their pressures are normal, or the ocular hypertensive, for capping, glaucoma suspect, where you're going to decide, do I treat, do I not treat, is this an asymmetrical disc size, is this, you know, there are those ones where you're really not sure. And these are cases where OCT really comes in handy. And the main thing, you should also know how to interpret it. But the extreme cases, I don't think necessary. And but those ones in between where you're not sure, but don't sell a goat. Just start on treatment if you think she really has glaucoma. Faith, what do you think for the visual field?
So my indication is the same. The only thing sometimes I add, like I tell the patient to do a field, even if it's much later, even if it's after, because some patients, it's part of the counseling. When you tell them and their relatives that your field is a bit reduced here and there, they also believe. So it does help in complying to the treatment. I also use it as part of my counseling regimen, but not early. If the patient can't afford, I don't put it early. Yeah.
Thank you, Faith and Shira, for those excellent presentations. And you see all the charts coming up. People are really happy to be well educated. Because of time, now we could want to close that and give 5 minutes to Pauline, the sponsor, to tell us one or two things. Faith, maybe you can stop sharing your slides. And
Okay.
Pauline, take it away.
Okay, let me try to share. So, are you able to see my screen?
Not yet.
I don't know if I'm sharing. Okay. Just a minute.
But we can see you.
I'm trying just share.
Vera, are you able to share a screen?
I'm not able to share.
Yes, she should be able to share.
I think I'm not able to. Just a minute. Just give me a minute, please.
Kindly hang on for Pauline and see what participants have reduced. Let's hear what she has for about 5 minutes before we say.
Just a technical error. I just want to share my screen. A minute, please. Yes.
Good, we now.
So thank you, Prof. Kiag, Dr. Masila, and Dr. Markov for this priceless moment. We are very much grateful from Allergan. So from me today, I think let me on. Yeah, you can see now. Yes, so sorry for that technical error. So my today's presentation is basically looking at why early effective treatment is important for your patient. And from Allergan, we say we protect the every moment matters, every millimeter of mercury matters. So oh dear. I think I have an issue. Sorry. So sorry for that again. So we've had visual fields, and they're usually an important function in assessing glaucoma progression. And we've heard that in early glaucoma, you find that visual fields remains relatively stable. And whereas in later stages, you find visual fields decline quite rapidly. So, and you by the tissue field loss is identified, up to half of the retinal ganglionic cells may be lost. So in our setup, that this is where majority of the glaucoma patients are usually diagnosed and treated. And a question that we could be asking ourselves is that could treating earlier preserve sight for longer? I want to share a new model by a guy called Professor Hagel. He was basically trying to look at, by changing visual field rate of progression, a patient's quality of life can be for longer. And he came up with a model by looking at a moderately progressed glaucoma aged about 57 years with a mean deviation of -5. And he looked at this patient normally with a rate of about 0.6 decibels per year. The patient will have developed serious visual field loss at around 77 years. This he got from the early manifest glaucoma trial, where you find on average a patient progress at this rate. And that with an extra deduction of just about meter mercury, you'll find that the progression decreases between 20 to 30%. And for that, the patient will have reached at -15 decibels at around 84 years. Therefore, coming up with the 7 saved sight years with quality of life. So from Allergan, we only have 4 main glaucoma products, ranging from the PGAs and the non-PGAs. Initially, we had the Lumigan 03, and currently we have the 01. There's the Gunfort, which is a combination of, which is bimatoprost timolol combination, alpha-Gan P, which is basically bromide tartrate, and Combigan, which is a combination of brimonidine, timolol. As of today, I'll be looking at more of the Lumigan, which is the PGA class. When you look at the bimatoprost molecule, we say that bimatoprost is the only prostamide with a dual action. And in this is because it comes as a prostamide, and prostamides are different from the prostaglandins. This is because in terms of, are usually clinically different in terms of pharmacology, biosis, and clinical potential. The prostaglandins usually are the likes of latanoprost and the travoprost, which have come. And with this kind of dual mode of action, it gives Lumigan an upper hand in IOP drop. So looking at current studies, actually lots have been done to compare the efficacy of Lumigan with the other PGAs. And these studies was actually with over 10,000 patients, and it had uncontrolled patients who on other PGAs, that is the tafluprost, latanoprost, and travoprost, and another group which was more of the naive patients. The uncontrolled were put on Lumigan, and the naive patients started on Lumigan. And because of the power of bimatoprost, you find that the IOP drop is quite significant from the switch patient or the naive patients. When you look at comparative data comparing the effect of Lumigan 01 versus 03, another study was done looking mainly at four, mainly to look on similarity, that is based on efficacy. Is it the same as 01? Yes. Efficacy between the bimatoprost 01 and 03 was similar at all time points. When you look at the hyperemia profile, that is the profile, the Lumigan 01 was much milder. Dano IOP also quite is equivalent to the Lumigan 03, and the discontinuation rate of 01 was much lower as compared to the 03. So this final slide that even in early glaucoma, you find that patients' quality of life is very much affected. And the recommendation is usually treatment from the start. Just listen in for a while. So I think that ends talk. And just an endpoint, Lumigan presents as 01 in a 2.5 ml bottle, a dosage of once a day, and usually requires no refrigeration. Thank you.
Very much to see prescription flowing in. And I like that little film because that presents exactly what the patient sees. Some people think they see dark, but every patient will say they see like smoke. So that is more of what I hear the patients. So thank you, everyone. I think it's past 7, and I wish to take this opportunity to end this. I don't know if there's any final word from OSK. So if I don't hear anything from OSK,